My name is Hudson. I'm an oncology nurse. I've been nursing for over 40 years, and throughout those 40 years in nursing at various stages I've worked in cancer care. I've worked as a surgical nurse, managing a surgical ward where lots of the patients underwent surgery for cancer. Latterly I've been working in oncology, where I work on an oncology unit. I'm semi-retired now. Before I retired 2 years ago, I managed an oncology unit down on the south coast, and that's where we delivered cancer treatments, usually chemotherapy and other drugs and medication to patients who were undergoing cancer treatment. Since I retired and moved to the north, I work 2 days on an oncology unit, still delivering cancer treatments to patients. It's very hard to give up, very hard to not work with cancer patients. Prior to that, I was a clinical nurse specialist working in Sheffield with patients who had rare cancers, sarcomas and endocrine cancers. So I do have a lot of experience in surgery as a clinical nurse specialist and as an oncology nurse, chemotherapy nurse. I have also a diploma in palliative and supportive care, which I undertook while I was working as a clinical nurse specialist, which was in Sheffield. So that's me. So I'm semi-retired, still working in oncology. Not sure I want to give it up quite yet. I first encountered Cancer United when Jan and Dwayne came to talk to our oncology unit several years ago, not long after the gym was first set up. And they talked to us about the journey that Jan had taken and what they were trying to achieve with Cancer United, with the support group, and also latterly with the gym and exercise for the cancer patients. And not just myself, but all the team and the other cancer nurses within the trust were all absolutely blown away by Jan's presentation and what the goals that they had, the ambition and the energy and the enthusiasm for helping patients who are undergoing cancer treatment, finish the cancer treatment and living with cancer. And then I contacted Jan several months after that because my daughter had sent me some information from Australia about cancer developments and exercise in Australia, some research that was being done, and Jan contacted me back and we've been in touch ever since. I wanted to get involved with Cancer United. I was invited to get involved and felt very privileged to be asked because the vision that Jan and Erica has is so widespread. They want to develop the training and the exercise programs for cancer patients throughout the United Kingdom. And that was such an amazing goal to have and such vision, and they've got such energy and enthusiasm, and I wanted to be part of that, to try and give something back. I've had a really amazing career. I've met some very special people, mostly including the patients, and to give something extra. Nursing is a very difficult job and often you don't have time to give them, the patients, exactly what they need, but this was something that I could give back to people on top of nursing. Cancer United work to me is invaluable because I have seen it change people's lives. I have worked with patients who I've been treating with chemotherapy and have attended the gym and the support group, and I've seen how much the patients have grown. They've found a new sense of themselves. Cancer patients lose so much of themselves, and this charity just gives people so much back. It gives them a sense of their health back, a sense of well-being, and a sense of who they are as well. And it gives them a chance to connect with like-minded people. And it's not just all about the cancer, it's about well-being as well. I've been teaching with Cancer United on the training programme since the very beginning, and I can't even remember how long ago that was. I think we started developing it about 5 or 6 years ago now, and I was very lucky to be invited to be part of developing the programme. Though there's cleverer people than me who did most of it, and I've done my presentations and been very happy to be part of it. The previous courses that we've taken part in, they've been at different locations. There's been one at the University of Brighton, if I'm correct, the University of Hertfordshire. We've been to Harrogate, we've been locally on the south coast as well. The last one that we did was in Harrogate, and fortunately I managed to stay for all of the days. Usually after the first day I've had to return back to work and just stay for the first day, but this time in Harrogate I've stayed with my husband, who was also a participant in the Cancer United gym and took part in the Harrogate teaching as well. We stayed in Harrogate for all of the days, and that was really amazing. The participants in the programme, they get such a lot out of it. You can see the brains whirring all the way through, and they just soak it all up, and you can see that they're really interested in getting started to work with the cancer patients. It's a real privilege to try and pass your knowledge and information on to the people who are interested in taking part in the course. Common questions I get asked from attendees. People are very interested in, once we've talked about what cancer is, people are very interested in individual stories and how we can help the individual patients. There's always a lot to talk about, talking about patients, but they also want to know about the treatments and how the treatments affect the patients. And I think sometimes they're worried because they hear and through the presentations how debilitating the treatments can be. And I think sometimes they're a bit concerned that they're going to be making things worse for them or trying to overstretch them. And I think just to reassure them that the patient or the client will let you know as well, and working with you how things will go for them. When I heard that the course was going online, I thought it was absolutely fantastic, mainly because it will reach more people, and people who are anxious to have this training as part of their work. I think it'll be such a benefit to people that if they can do the work online, they don't have to travel. They can pick it up when they've got free time. And I think it'll be a real bonus. It'll certainly reach more people. Obviously face-to-face is good as well, because people have got opportunity to ask questions there and then. But online has absolutely got a million advantages too. So this is the first of my 2 presentations today, and we're going to look at a brief introduction to cancer. Okay, so I'm going to give you today a brief overview of what is cancer. We're going to look at the incidence of cancer in the United Kingdom with figures from Cancer Research UK. We're going to be looking at what the risk factors are for cancer. Also, how cancer is diagnosed and staging of cancer, which is very important when deciding how to treat cancer. And also we're going to touch upon palliative care. To understand what cancer is, we need to know how our body is made. And looking at this slide, it illustrates that we're made of billions of cells. They're all specialised and develop their own functions. The cells form together and develop into tissues, and the tissues develop into organs, and then into different biological systems which form our body. And as you can see, amazing statistics, 300 billion new cells every day are developed, which is 200 million per minute. You can see on this slide that each organ and tissue type has its own specialised cells, which is very important when we're diagnosing what cancer a patient actually has. The cells will be looked at under a microscope, and the cell type will give what cancer it is. So the earlier slide told us that we produce 200 million new cells per minute. This slide illustrates a normal cell cycle, so it's how the cell regenerates and renews itself. So looking at the slide, the cell goes through several phases before it actually divides and producing what we call a daughter cell. And the cell will either rest for a while, a few days even, or it will have a natural death. And that natural death, cell death, is called apoptosis. After a few days, the daughter cell will go through the same cycle of division, rest, and natural death. This process is controlled by what we call signalling pathways, which are chemicals within the cell and which surround the cells. So what actually is cancer? So cancer is the uncontrolled rapid growth and division of the cells. The cancer cells don't follow the normal pattern of the cell cycle. The cancer cells can evade the normal process of cell death. And also there's a change in the signalling pathways which would normally control cell division and cell death. And also there are changes to the DNA in the cells, which changes how the cell functions and help it to evade death as well. So this slide illustrates the difference between normal cell division and cell death and a cancer cell division. As you can see, a normal cell division goes through the normal process, and any damaged cell or old cell will die off naturally through apoptosis. A cancer cell division, as you can see, it's uncontrolled and there's no cell death there at all. It just keeps dividing and dividing and growing and growing. So cancer cells will grow faster than a normal cell. They will divide more rapidly and they will divide faster. And it takes actually a lot of energy for cancer cells to grow and divide. So often you'll find patients lose weight because the energy that the cancer cells is using takes up a lot of energy from the body itself. So from this rapid uncontrolled division of the cells, a tumour is formed. There are many different terms to describe a tumour. You might have heard terms like a lump, a mass, a growth, a lesion, neoplasia, which is a bit more of a medical term, but all of these terms describe a tumour. But a tumour can also can be benign or malignant. A benign tumour doesn't spread, it's localised, it stays in one place. That doesn't mean that they can't be problematic, because depending on where they are, they can grow, and they can, say, if you have a benign tumour in your brain, it's not cancerous, but the benign tumour in your brain can grow and can cause loss of function, can cause blindness, can cause pain and debilitation. a malignant tumour is different to a benign tumour. A malignant tumour can spread to other parts of the body. Cancer cells from the tumour can break off and spread via the blood vessels or the lymphatic system and form secondary tumours, which we call metastases. The secondary tumours, metastases, tend to spread to the liver, the lungs, the brain, the bones and the lymph glands, and often it depends on where the original tumour is as to where the site of the secondary cancers are. So this slide illustrates how a tumour is formed. And so the cancer cells, they divide rapidly and grow together and stick together amongst the normal cells. So you can see from this slide that the cancer cells have broken through the tissue boundaries, and it looks as if this cancer is about to spread. These figures are from Cancer Research UK, and they're the most up to date. They might look as if they're a bit behind, but I guess it must take a lot of time to gather incidence and figures together. So incidence of cancer in the UK, so there are over 367,000 new cancers per year, and they're the figures from between 2015 and 2017. More than 50% of these are the common cancers that you hear about, breast, lung, bowel and prostate. Unfortunately, over 1,000 cases of cancer are diagnosed every day. And many of these come through screening programs. We have screening programs for breast cancer, bowel cancer, and cervical cancer as well. There's a lot of public awareness campaigns, such as for lung cancer and for melanoma. But someone in the UK is diagnosed with cancer every 2 minutes. The incidence of referrals for cancer during the COVID pandemic has dropped. The oncologists, the surgeons have seen referrals from GPs drop exponentially. There will be many reasons for this. Patients who wouldn't normally go to the GP haven't been able to see the GP, or they've been scared of contacting the GP in case they're called into the surgery or called in for investigations in hospital, and sometimes patients have been more scared of catching COVID than finding out if they've got a problem that needs diagnosing. I know of patients that I have treated who have tried to speak to their GPs during the pandemic and have had telephone consultations. They've not been sent in for investigations, and they've actually at a later date been diagnosed with cancer, and in their opinion they feel that their cancer diagnosis has been delayed because of COVID and not being able to speak to a GP or see a GP or get the investigations that they need. We are seeing a lot of referrals come through now that the pandemic is relaxing and the COVID regulations are relaxing. We are seeing an awful lot of referrals, and the waiting times for cancer treatment is going up, which is very sad to see. It's very important that if a patient has cancer, they are diagnosed as quickly as possible, because they need to be treated as quickly as possible. The earlier the cancer is diagnosed, the better outcome for that patient. Unfortunately, even before the pandemic, over 50% of cancers were diagnosed at a late stage, and that's before the pandemic. So we're expecting the statistics for that to be even higher looking through the pandemic era. Looking at more figures, more than 36% of people with cancer in the UK are over the age of 75. And also the highest incidence of patients with cancer are people who are between the age of 85 and 89. So although it can be seen as an old person's disease, it's not always an old person's disease. 1 in 2 people born after 1960 will also be diagnosed with cancer. The figures until the last few years were 1 in 3 people would be diagnosed with cancer, but it now is, sadly, the figure is now 1 in 2. And since the 1970s, there's been an increase in 30% of all cancers. And looking at those figures, 37% in females and 17% in males. The increase in figures is partly down to improvements in investigations and diagnosis, but it's also down to increased risk factors for cancer. The most common cancers in men are prostate, lung, colorectal cancers, but also, which is also known as can be known as bowel cancer, and bladder cancer and non-Hodgkin lymphoma, and that is a blood cancer. Women, as you might expect, is breast cancer, lung cancer, colorectal cancer, endometrial cancer, which used to be known as cancer of the uterus, and ovarian cancer. Survival rates in the UK, for all cancers, 50% of patients are still alive at 10 years. So that's a 10-year survival rate. Again, these are old figures between 2010 and 2011. 2.5 million cancer survivors are in the UK now, and we'll talk about what a cancer survivor is later on. However, there are still over 166,000 deaths per year from cancer. And the most startling figure is 38% of those deaths are preventable. Survival rates also depend very much on the type of cancer that has been diagnosed, and also whether it was diagnosed early, as we spoke about earlier, and if it has spread, so if it has metastasized somewhere. And as I said, almost half of cancers are diagnosed at a late stage. The 10-year survival rates for breast cancer are 78%, for prostate 84%, for colorectal cancers it's 57%, but for lung cancers it's only 5%. So this slide looks at basic risk factors for cancer. A genetic predisposition to cancer is a big factor. You may have heard of the BRCA1 or the BRCA2 gene, which is the Angelina Jolie gene, which affects breast and ovarian cancers. There's also familial predispositions to cancer, such as for bowel, breast and prostate. But also contributing factors can be past medical history, age, as we've already discussed, hormonal influences, which we'll discuss in more detail in my next presentation, diet and nutrition, environment, lifestyle, and also past treatments. If someone has had chemotherapy or radiotherapy for a cancer in the past, there is a risk that this can cause a further cancer in the future. Lifestyle plays a major part in cancer risks. Smoking, alcohol, obesity, diet, lack of exercise, and exposure to UV rays. And also environmental factors, including radiation exposure, chemical exposure, and now we're seeing more and more due to pollution. So we'll talk about diagnosis and staging of the cancer, and there are strict rules about how long a patient can wait before they say that they are referred to a specialist, and how many days or weeks between the specialist seeing the patient and when they're diagnosed and when they're treated. So if the GP suspects cancer in a patient, they'll be referred to a specialist and be seen within 2 weeks of that referral. So that's called a 2-week wait rule. The specialist may then examine the patient, arrange investigations such as x-rays, scans, blood tests, biopsies. And then once all of these results of the tests are in place, they will be discussed at a multidisciplinary team meeting. And at that meeting, it will be for this speciality. It might be a breast multidisciplinary team meeting. It could be a sarcoma or colorectal. All of the results will be discussed. At the meeting, there will be a surgeon, a radiologist, a pathologist, an oncologist, and a specialist nurse in attendance. The diagnosis will be made at that meeting, and the patient will have to be diagnosed within 31 days of being seen initially by the specialist. Then the decision will be made there and then as to what is the best treatment plan for the patient, and treatment needs to commence within 62 days of the initial consultation. So these are what we call the 31-62-day rules, and all trusts, hospital trusts, have to adhere to these rules. And if they cannot get the patient seen or diagnosed or treated within those rules, the trust can then be fined. So it's a financial motivation for the trusts to get these patients through and seen quickly. So then we go on to staging of tumours. So this is looking at the extent of the cancer within the patient and how the decision is made whether the tumour is operable or how to treat the tumour. So the system they use is to stage a patient's tumour is the TNM system. So T looks at the size of the tumour. So a T1 or a T2 tumour is a small tumour. A T3 is larger but probably still operable. And a T4 is generally too big to be operated on. N looks at whether any lymph nodes surrounding the tumour are involved and have been invaded by cancer cells. So if there is nodal involvement, N1 would be not so many nodes are involved, N2 multiple nodes are involved, and N3 bilateral nodal involvement around the body or distant nodes are involved. And then M means that the cancer has metastasized, it has spread to other organs in the body. And generally, this means that the cancer is incurable. So then the whole of the tumour is further staged. So an early stage of a tumour, a stage 1, means that the tumour is either a T1 or a T2, so it's a small tumour with no involvement of lymph nodes. Another early stage, a stage 2, it might have a few lymph nodes involved around a small tumour. Then we have a stage 3A, which is a locally advanced tumour. So it might be a slightly larger tumour with a few more nodes involved, and often this one can be operated on. A 3B would be a much bigger tumour with more nodes, and that would mean that it wasn't operable. And a metastatic is a stage 4 tumour, and that means that there's been spread to distant organs, and that is generally uncurable. So when we're talking about treatment of cancer, there's generally 3 different ways that treatment can be done. A treatment of cancer, they may have 1 or more treatments, so they may have radiotherapy, surgery, and some systemic anti-cancer therapies, such as drugs or medication, such as chemotherapy. So they may have 1 or all of these as part of their treatment. So surgery is usually for early cancers, and they're hoping to cure the cancer with surgery. Radiotherapy, that's with high energy X-ray beams and targeting the tumour itself. And it can be used by itself, or it can be used in combination with surgery and chemotherapy. And systemic anti-cancer therapy, which is, I'll talk about a little bit more later on, is drugs and medication to treat the cancer. And it includes chemotherapy. Palliative care. Not all cancers can be treated, and the patient may need input from a palliative care team who will holistically assess the needs of the patient. They will work with the patient and family to help them live well and also to die well wherever possible. And to do a holistic assessment, you need to look at all aspects of the patient's life and take all that on board when you're planning a patient's care, and you plan a patient's palliative care with the patient. Earlier on in the slides, we saw that 38% of cancers are preventable. Smoking causes 86% of lung cancers. It can also cause head and neck and bladder cancers, as well as esophageal cancers and other cancers. Alcohol can contribute to esophageal, breast and bowel cancer. And red and processed meat is known to contribute to bowel cancer also. So we need to eat healthily, we need to be active, which is where you come into play. We need to take up screening programs. We need to be a healthy weight, we need to be smoke-free, and we need to limit our alcohol. When we say about being active, you're going to hear this all throughout the course. Physical exercise can prevent cancer, can help treat cancer, and it can control cancer. You may come across the term cancer survivor. It's not a term that many people like to use in the UK. And there are several definitions, and each individual will choose if they are a cancer survivor or not. But often they talk about patients who have completed treatment and they've got no signs of active disease. Also, people who are living with progressive disease, but they're still alive, they're still able to live the life that they want. Patients may be receiving active treatment, but they're not terminal, so they're still in the middle of their cancer treatment. Terminal patients tend to be patients within the last 6 months of their lives, and that's when hospice care and palliative care would be involved. But also a survivor is someone who has had cancer in the past, and they may be just living with cancer, or they have no active disease at the moment. So survivorship means different things to different people. So hopefully that's given you a basic understanding of what cancer is, some statistics, how cancer can be treated, and in my next presentation I'll be discussing in more detail the treatments for cancer and their side effects. So thank you for listening.